I'm pleased to welcome Dr. Tanaz Ferzandi as the moderator today. Dr. Ferzandi is the Director of Urogynecology and Reconstructive Pelvic Surgery, an Associate Professor of Surgery, and the Associate Fellowship Director for Urogynecology and Reconstructive Pelvic Surgery at Keck School of Medicine of UFC. In addition, she is the Service Line Chief of Obstetrics and Gynecology at Keck Hospital of USC and was elected to serve as the Secretary and Treasurer of the Keck Hospital Medical Executive Staff. Dr. Ferzandi, thank you for being with us and moderating today.
Jenny, thank you so much. Good afternoon. I'm Tanaz Ferzandi, as Jenny mentioned, and I'm very excited to moderate this session today in a conversation with our esteemed panelists, basically on balancing clinical and administrative practice. Before we get going, I do want to take 2 seconds to thank Jenny and the ACS staff. I think we recognize a lot of work goes on behind the scenes that we, to get these things up and going. And so I do want to make sure I do that before we end the session. So we are very fortunate to welcome 3 incredible surgeons and leaders who experience clinical practice and administrative roles very seamlessly. So I'll get started and introduce each one of them, but I can assure you that we don't have time to go through their entire CVs. Dr. Cherisse Berry is the Vice Chair of Academic Affairs and Professor of Surgery at Rutgers Health, New Jersey Medical School, Department of Surgery, Division of Trauma and Surgical Critical Care, and the Director of Research for the Eric Munoz Trauma Center at University Hospital in Newark, New Jersey. She's held numerous national leadership positions with the American College of Surgeons, American Association for the Surgery of Trauma, Society of Black Academic Surgeons, and the Western Surgical Association. Welcome, Dr. Berry. Dr. Nancy Gantt is Professor of Surgery at Northeast Ohio Medical University, NeoMed, and the Breast Program Director of the NAPBC-accredited Joni Abdu Comprehensive Breast Care Center, Bon Secours Mercy Health, Youngstown, Ohio. At Mercy St. Elizabeth Youngstown Hospital, she serves as the Associate Director of Resident Education. Dr. Gantt is the Vice President. I'm going to say that again because I want to get it right. Dr. Gantt is the first Vice President of the American College of Surgeons and the current Chair of the Association of Women Surgeons Foundation. Welcome, Dr. Gantt. Dr. Jennifer Rabaglia serves as the Chief Quality Officer of the UC Health System, University of Colorado, where she is charged with developing and implementing a system-wide quality program structure that provides strategic direction to enhance quality, improve outcomes, and advance the culture of safety across UC Health's 14 hospitals, 600 plus ambulatory clinics, 5,000 plus physicians and APPs, and about 33,000 employees. So not a small task. I thank all of you for being with us. To start things off, I'd like each of you to share what motivated you to pursue roles outside of the operating room and our traditional clinical practice. Dr. Gantt, I'd like to start with you first, please.
Thank you so much. It's a great question because everyone's inspiration for doing this is different. I've always been drawn to the broader impact I can have outside the operating room, just like everyone else here this evening, whether it's teaching or mentoring or solving system problems just to make the patient's experience better and my fellow surgeons and all of our teammates have a better experience. So right now, I'm in a position where I'm the institutional breast program lead and also trying to maintain NAPBC and COC accreditation. Having a dual role of leadership within the college makes that seamless. It's wonderful. And I've really, learned so much more about institutional standards, pairing that with professional excellence and benchmarks. I think one problem that everyone in the room here probably has, and that most of the people listening tonight have, is the fact that as women, we get sucked into non-promotional administrative duties. I think we all end up doing institutional housekeeping. And I mean, we all do administrative roles, probably from the time we're a chief resident in surgery. And we do administrative things because we're really good at it and things really get done. I read a great book called The No Club, which is by a bunch of professors from CMU. And they, really wanted to put a stop to all the things they were taking on that were dead ends. They were not associated with promotion. So I was very careful about choosing administrative roles throughout my career, trying to make sure that they met my personal mission of quality, excellence, teamwork, and all those things.
I love that. Administrative housekeeping. So our jobs never end with that task. Dr. Berry, how did your responsibilities and priorities shift when you started to take on more administrative and leadership roles?
That's also a really great question. I think for me, with each leadership role, as sort of medical director and then division chief, and now as vice chair of academic affairs, my responsibilities really shifted from individual care of the patient and team management to really building systems to support our patients, our programs, and sort of outcomes. When I was medical director, I was very much responsible for operational efficiency, quality metrics, and really translating data into improved patient outcomes and making sure that we were sort of in compliance with hospital standards, all while addressing disparities in how we deliver the care. When I was division chief, I really focused on sort of aligning clinical operations, recruiting diverse faculty, and really building a team culture really rooted in excellence and mutual accountability. And now, as vice chair of academic affairs for the Department of Surgery, my priorities really have broadened. Really focused on academic and professional development across the department for our faculty and for our residents, ensuring that we have access to mentorship and faculty development. And so I think across all of these roles, the common thread has really been sort of a shift from reactive problem solving to really proactive system building, really using sort of a data-driven approach with collaboration and intentional leadership really to drive lasting change. So the scope of the responsibility has widened, but the potential, with the potential for meaningful impact.
Thank you very much. How long do you think you've been in some of these roles, kind of jumping out of the clinical realm? I'm just curious as you've kind of diversified.
Yeah, I've been in these roles over the course of 7 years.
Okay. Just to kind of give some framework as to how long some of this kind of takes, actually. And I think Dr. Gantt, can you kind of reflect on how long it took you before you kind of changed your trajectory a little bit?
So I was involved in the development of our comprehensive breast care center before we even broke ground. I've been involved twice before in great big task force where we were going to get a breast care center, and then all of a sudden a new CEO rolls in, and even though you've done so much work, they head in a different direction. So we finally had a committed surgeon who raised $15 million from community donations, and we developed the breast care center, and I've been the medical lead ever since, and that's been over 12 years. So there was a gradual transition, and now the majority of my time is spent on administration, teaching, mentoring, things like that.
Yeah, and I do think that's important because even for someone like myself, like a lot of this takes time, and then a lot of it, you do a lot of the work, and then all it takes is someone's role shifts and their energy shifts, and then you're back to square one. But thank you. Dr. Rabaglia, what skills from your clinical background have been most transferable to your administrative work? And just, as I introduced you, you're doing a lot of stuff outside of the clinical realm right now. So I'm just intrigued.
I think, surgeons have a very unique skill set, and the skill set that we bring to the table is so applicable to a wide variety of things across healthcare. And so I think the ability to rapidly discern signal from noise is a really key skill set that we have honed just because of our craft. And it's that ability to translate to the ability to rapidly digest large amounts of information, sometimes coming from multiple sources, disparate sources, and distill it down to that elevator speech. And that's a hard skill to hone. We all were med students at some point where we were on our first medicine rotation and had to give that, take all that information and give that 30-second blurb to our attending. But honing that skill, we've done that, and we bring that to the table as something that I think is pretty unique to us. There's also that element of being comfortable with being uncomfortable. And I would say in these large administrative roles, there's a lot going on. You may have to make decisions that are outside of your lane. They're outside of your subject matter expertise. But you have to get comfortable being uncomfortable and being able to, assimilate that information and make those decisions, sometimes based on limited data sets, which is something that I think we also do in surgery often. So I think there's a lot of translatable skills that we have that can be applied across a wide variety of roles.
And kind of your trajectory and timeline, like how long do you think from, starting off as a fresh young faculty member and, just wanting to see patients operating to kind of this trajectory that you have taken, which really has taken you outside of what we do day to day?
Yeah. I would say the predominant piece of it is over the last 10 years. It started from the beginning of faculty, actually, when I was doing my master's. And taking on small roles, niche roles related to quality and things I was passionate about, and then grew from there. But I would say over the last 10 years, it's been that transition from really the micro to macro, that, things I was doing in surgery to then, a bigger role that had a broader scope and across multiple disciplines, and then just growing off of that.
Thank you. Dr. Gantt, I'm going to popcorn back to you. What challenges did you face when balancing these clinical duties that you continued with responsibilities administratively? And overall, how do you continue to just manage, right? Because I think we all touched on it. We also have all these other responsibilities outside of the hospital environment. So I think we'd like some insight on how you've done it gracefully.
We could talk about this for hours. We really, all of us could.
Yes.
So, as surgeons, we are extremely organized. We're very efficient. We have strong personalities, right? So I've had to become even more organized, I prioritize things even more. I'm better at delegating. I'm working really, I really rely on my team. The biggest problem is when you don't have someone on your team that isn't as mission driven as you are. I make sure that my clinical mission and my administrative mission completely line up. It's challenging. Time management is, I think everyone would agree, it's the hardest part. And then maintaining the incredibly high standards that I set for myself clinically, and also as far as in my administrative duties, when the administrators I work with, their bar does not seem to be as high as mine. Maybe administrators elsewhere are different, but my bar is so high. I'm also a very different leader, and that's been a little bit of a challenge. I think in the operating room, I try to be democratic, but I kind of veer into being autocratic at times when things need that, when they need me to do that. And then there's a little bit of coaching, and then when I'm not in the OR, but still clinical, I try to be a servant leader because my team does so much for me that I really want to give back and encourage them. But then when you're in this whole other environment where I try to be this transformational leader, I'm making things better, I'm doing things differently. It's like I'm pulling out different hats and putting them on all the time. And there also is so much less positive reinforcement. I'm sure everyone, when you operate and you're done with a case and everything's gone so beautifully and you're so excited, and then you do a few things and then you go do another case and it's great, mostly great, everything. So you get home at the end of the day and you've had all those wins. And now if I have a purely administrative day, sometimes I don't feel like I've had any wins at all. I feel like I've been herding cats all day. So I'm changing my own personal expectations of what success looks like. And I'm sure I'd love to hear what everyone else has to say about that, because it's very interesting to reflect on how different you have to talk to yourself about your day and your successes when you're in these different roles.
And I want to touch on something you mentioned because I think we all know this, but I'd like to highlight it, and all of you, I'd like to interject here, the strong personality of the surgeon, like the stereotypical strong person. And then you marry that with being a woman in an environment, you put those things together, kind of the delicate tap dance you have to do, and then you throw that entire package into the non-clinical arena where most people, as you kind of suggested, aren't the surgical mentality to begin with. I mean, I'd love to hear all of you talk about how do you tap dance around all of that? And please just pipe in because I'm still struggling with a lot of that.
I think it's interesting because there are a lot of stereotypes around what a surgeon is and how a surgeon communicates and how they behave. I think to be in some of these roles, you need to have a lot of soft skills. You have to be able to navigate. You have to be good in a living room, right? And so it's interesting because I think people come in the room with a specific expectation of the interaction and they leave the room thinking, that actually was not the way I expected it to go or who I expected you to be. And you do have to put on those different hats as you walk into different settings. And it's a little bit about knowing your audience too. There's some times when the surgical approach is the best one. And there's others, where you need to shed some of those stereotypes and, come in with a different hat. So
I think that's picking your battles a lot and also how you portrayed. Dr. Berry, this is tough, right? So how can early career surgeons prepare for a future that includes both clinical and non-clinical roles as you have? If you were going back and talking to your younger self, as we like to say, how would you navigate it? What advice would you give to this generation that's looking forward to stepping into shoes like yours?
I would say that, the first step really is recognizing that leadership isn't just about a title, that really it's about a mindset. I think that I would encourage early career surgeons to really get involved in their hospital committee, a QI project, really building their leadership skill set such that when opportunities come around at a regional level or a national level, that they have the skill set to be able to perform very well. I think knowing your why is very important. That you want to make sure that your whatever administrative role that you want to pursue aligns with your values, and that you have clarity in what your values are and what the role is, and that they are aligned, so that you will remain grounded.
Thank you. Dr. Rabaglia, what are the common misconceptions about administrative roles in surgery? Things that you may have encountered or you just know are out there?
I think there's that element of you've gone to the dark side, right? You were one of us and you're no longer one of us. Now you're one of them. And we don't like them, right? It's the mysterious and nefarious them. And all of a sudden you magically lose your surgeonness. It's like overnight, right? Because you've made that transition. There's, I think, also some perceptions out there that these roles are somehow less than, less impactful, less skilled, less demanding, because we live such demanding lives as surgeons, right? And we look across and maybe it seems like it's a very different in terms of how they're constructed. I'm not sure that there's always an appreciation for the demands on your time or the nature of the stressors are different. These roles still are challenging, demanding. It's a very different type of challenge, but bring a lot to the table. And I think those are some of sort of the misperceptions of administrative roles.
And then, Dr. Gantt, how do you maintain your clinical identity, kind of the thing that brought you into this whole arena to begin with, while taking on more and more of the non-clinical responsibilities that we've been talking about?
So that's such a great question. So, my role as a surgeon is the entire foundation of my identity. It is for all of us. I mean, we've given so much to get where we are. But I am so not Cherisse Berry. I mean, I barely have street cred with my residents because I'm just a breast surgeon. I have to remind them that yes, I can do an ED thoracotomy, and yes, I can do a Whipple. It's, so being a breast surgeon is almost lesser than, because it's not regarded as difficult, which is certainly a challenge. But as my clinical activity has dropped down a little bit, I've just become even more present at all of the educational activities and made sure I was still an advisor to the residents. I'm still mentoring medical students. Our medical school is about 45 minutes from, or about 30 minutes from the hospital. Still involved, don't miss an M&M conference, don't miss an interdisciplinary breast conference, and make sure that if I'm presenting, especially if I'm doing anything at the Clinical Congress or at the American Society of Breast Surgeons, that everyone knows I'm doing that. That they know that I'm doing that, which means that they could be doing that. It's not out of the realm of expectations that they could put together a presentation and also present at a major national conference.
So I think that's interesting. And I just want to kind of poke at that a little bit, because you brought up something that listen, I come out of an OBGYN environment. Trust me, I know all about the tier level of how much respect you get in the operating rooms and stuff like that as well. I mean, that's an additional burden to really kind of walk around with, right, as women, because it's like we already have those layers. And on top of it, there's another layer of, are you really that top-notch X, Y, and Z? And so it's almost like I feel like you're suggesting, and I think Cherisse, she brought you up, how do we balance all of that and not play into this type, like the stereotypical stuff that we're all kind of fighting against, but we know we kind of have to play into as well. I mean, still feel like I'm doing this because I love it. Like, do you guys have little mini pep talks with yourselves? Like, how does this work overall? Cherisse, I'm looking at you.
I was just gonna chime in. I think, Dr. Gantt really you said it, that it's being present, it's being engaged, it's, you're taking care of your patient, whatever the ailment may be, you're there. You show up, you're there with your team, you're delivering excellent care, irrespective of what specialty that you are in. You're caring for your patient and you're delivering excellent care. And I think being there, being on the front lines, you can't do it, you're not 100% clinical, but when you are there, you're there. You're giving your 200%, and you're the trying to be that role model for your colleagues, for your residents, for your students, and that in and of itself brings the credibility by being present and being engaged.
One of the things, and I do want to make sure that we have time for question and answers too, but one of the things that we had actually talked about that I think will probably affect even the next couple of generations more so than us is, the financial tides in healthcare continue to shift. And I think I know so many people across the country that are feeling kind of that extra burden on productivity. And we kind of touched on this before we started the webinar today. And I'd really like all of your thoughts on what you are seeing out there so we can put that out there for our audience, because I'm sure it's a whole gamut of age ranges. But this whole idea that as you get tapped, because you're clinically and surgically excellent, you have all these other attributes that clearly got you tapped into these other roles, and you keep getting tapped to do more roles because you're so good at what you do. And then on the flip side, the healthcare machine has to keep rolling. And as surgeons, you are the people that continue to bring in the highest margin to the hospital for sustainability, right? No margin, no mission. And so what are the messages that you get or don't get? But on the front lines, it's all about productivity and how you have to bring in the volume, you have to do the cases, you have to see the patients, but then you're also trying to do these other things. And this is just kind of an open forum to try and have that discussion, because I know that on the ground level here, administratively, I'm taking on a lot of roles, but no one's carving out that additional time necessarily because they need me to see those patients, block times, cases, et cetera. So I just want to leave that out there and see what any of you have experienced, what you maybe forecasting is coming down the pike, so to speak.
I think that's where we really rely on strong leadership in our departments and making sure the leadership understands that we're doing things that are mission congruent with the hospital quality. I'm looking at Dr. Rabaglia. I mean, quality, it's all about quality, right? It's important to be COC accredited. It's important to do NSQIP. It's important to have quality improvement projects, engage the residents and medical students in those. That takes time, but it makes a difference. So I think we need to make sure that the leadership in every department, not just surgery, but also internal medicine, OBGYN, everyone else understands that it's a bucket, and there's the quality bucket, there's the educational bucket, there are all these different buckets. And yes, it's the RVUs, but uh, can we be a wellness-oriented society, a group, a community, and not an illness and disaster-oriented group? It's tough. I was very lucky to negotiate a salary contract, so I was able to balance surges in either administrative duties or clinical duties. And when disasters happen, I had room and time and flexibility. So I was very fortunate. It may not have been the dollar amount that a lot of my colleagues, it was probably half as much as my acute care surgery colleagues were making, but I was fine with that because I was able to balance my life better. I am better able to balance my life with that level of freedom from a set amount of RVUs that I need to get, even though my RVUs have been just fine.
I completely agree with everything that you just said. There needs to be a recognition that these roles bring value to the table. And if you're in an academic setting, it should look like a career pathway. The research career pathway, there's teaching career pathway, there should be an administrative career pathway because these roles are congruent with the mission. If you're in, any setting, there should be a recognition that, you need compartmentalization, right? You need the time and space to be able to do that. So whether it is a salary model or an FTE, there has to be some sort of resourcing and support to ensure success in the role. I've been similar to be lucky to be on more of a salary model where it takes that productivity element out of it. And I do have the time and space to focus on the things that I need to focus on. You might take a little bit of a hit in terms of what that salary looks like, but it's worth it to do the thing that you are most passionate about.
Dr. Berry, any thoughts on that specifically?
Yeah, I think that one of the things that's really important is ensuring that when you take on these administrative roles, that it is protected, and that the expectation that you're still going to be 100% clinical is sort of taken off the table. It's nearly impossible for you to be 100% clinical and then take on these, administrative roles and then, you're not being set up for success. And it's not very realistic because you need to be able to have the time to be able to devote and excel in the role that you're in. And so recognition that there is value in that administrative role that aligns with the mission of the institution and the organization to further their mission. So it's really valuing your time and valuing your role in the overall mission of the institution. So I agree with what's said before.
I want to be provocative, and Dr. Gantt, you mentioned this. What would you say to young women, young surgeons who may be in situations where they want to aspire to do the things that you all have, but they may not have a very supportive structure in their own local environment. Because that person, that chairperson, that division chief may have a lot of those pressures coming down on them, the productivity, engine that needs to keep moving forward. Anything that you may have learned on how to maybe circumvent that, or is that where we're
Besides looking for another job somewhere
well,
else?
yeah, I guess.
No,
Yeah.
we are, we're Olympic athletes, right? And we
Yeah.
are working so hard. We're taking such good care of ourselves so we can be incredibly productive and take such great care of our patients. We need to be in an environment that's not toxic and that's supportive. So, I'm a big fan of the org chart, and I'm thrilled now that when I hover over the email address of someone at my institution, it shows me this card of who they
Yeah.
report to and who they whatever, because it seems to be a newish thing. The org chart is it's your secret weapon, because if you're not getting what you need from the person directly above you, a completely casual conversation with the person in charge of them or even higher up, or the Dr. Rabaglia at your institution, someone who is, leading in quality. I'm mentoring several of actually, they were my residents and now they're my partners right now. One who is going to shoot up in the Society of Surgical Infectious Disease Society, because she is so into pathos and how crazy it is and is such a passion about it that I'm directing her. And she's negotiating, and when they say no to her, she'll do some other stuff, and suddenly they call her back and say, we really need you to help us with this. So finding your passions, um, realizing what you're good at, speaking to those, finding supporters within the administration of where you are. Because you're right, the person directly above you, your division chief or your chair, may be getting pummeled, just pummeled, and have no budgetary control and be responsible for so many things. So, not that you're going behind their back, but you're just finding out more information and perhaps volunteering your services for a fee to the quality officer at your institution or the perioperative division leader or whoever, whatever works for you.
I do agree, because I think a lot of people are stuck in kind of these ruts for various reasons, not necessarily nefarious, but for various reasons. And I think I don't want to say the workaround or the end around, but it is a way to go outside of your local silo and see if you can find mentors and sponsors and people who need help to do pet projects. And you raise your hand because and I think the other really important thing, and I've heard all of you mention the word passion. I do think it's important to have a passion for what you are signing up to do, because it's very easy for people on the other side to say that this isn't of interest. This person's just doing something to check off a box, etc. I do want to mention that we are going to be open for live Q&As, but I do want to keep the conversation going as well. Couple other things. As you all sit here today, obviously, as accomplished as you are, what advice would you give to surgeons who, understandably, in some circumstances, are hesitant to step into leadership or even administrative roles? Like, what would you say to those people that you may see something really good in and see that they can strive towards something, but they're hesitant currently?
I would say take the leap. These roles are opportunities for surgeons to really have a broader impact in shaping the future of healthcare delivery in all its forms. So we have a unique and valuable lens. We have a valuable skill set, and that extends far beyond what we do at the bedside. I think getting back to the passion question, that's the key, is if that opportunity aligns with your passion, then it will open up doors that you can't even see yet. And I think that that's the most important part, right? Is you have to be open to the opportunities that arise. Know what you want. Know exactly what Dr. Gantt said. Know what you're passionate about, and you'll start to see those doors open.
I would agree 100% with that. And I think, the more leaders that we have who are surgeons. We can get those leaders into higher leadership positions at the table to help make the decisions that are going to benefit our patients. We really need surgeons at the high leadership level because we, as you were mentioning, have that unique lens that often is not there right now. I think we need to be there. And so we need to be grooming our younger surgeons now to develop their leadership skills, to take them higher and higher and higher, so that those that are in the C-suite are surgeons and can actually deliver the message.
I think an important question to ask is, what is someone afraid of, right?
Yeah.
No one's going to die. Nothing terrible is
True.
going to happen.
I do think people are just afraid of failure because we're so,
yeah,
to succeed,
yeah.
right? So maybe that's
right. I understood. But if you don't go outside your comfort zone every once in a while, who are you, right?
Yeah.
Look at all the things we do without thinking twice about it. That all of our friends, I mean, the kids we went to college with who are off, being venture capitalists or something, or lawyers, they would terrify them what to us is just day-to-day activity. And we really are. Look, if someone says to us, "Oh, I'm afraid of taking that leadership role," you can look them right in the face and say, "You're a leader every time you step in the OR. You're a leader in your office. I know you're a leader in your community. You are a leader in so many." This is just leading something else. Certainly taking courses is always helpful. The ACS Surgeons as Leaders course is foundational. It is absolutely wonderful. And they've got a residence as leaders course in addition to residence as educators. So, coursework like that can really make you reflect on who you are and what are your strengths and, what are the opportunities for improvement. But this is what we do. We love success. Yes, fear of failure, sure. But, with us at the helm, it's more likely it's going to be successful. And if it fails, it's probably not because of something we did.
And I think those courses really are helpful because you're 100% right. We are leaders. We all do it every single day. But I think there is an art to certain types of leadership, especially when we're getting outside of our comfort zone. And then there's also an art to management. Just because you're a good leader may not mean you're a good people manager, and vice versa. And it takes a lot to get those two things together to really keep succeeding in roles that are a little outside of our comfort zone. So yeah, that's wonderful. And then, I think just to kind of tie some of this together, and you guys have touched on it, but in general, how can institutions, or is it even in their purview, support surgeons transitioning into these hybrid roles, to do both the clinical and administrative stuff? Dr. Berry, you mentioned it, can you guys think of other things outside of us trying to get our junior members into that pipeline, so to speak, so that eventually they'll be taking on these roles to continue that work? Is there anything else institutions might be able to do at places that you are at, you've seen succeed?
I've seen, fellowship tracks for different types of administrative roles, and those tend to be pretty successful. But it's really creating that career pathway, right? And valuing that career pathway. Because if you only value the research path or the teaching path, then it does not leave that avenue for people to go and seek that skill set, develop that skill set. So I think, creating a lane for people to do that is really important.
Just going to say that I think institutions really need to value both the clinical role and the administrative role, which we touched on a little bit earlier. And they show that value by protected time and by appropriate training as well as compensation. I also think that institutions really need to be transparent with, the administrative role. Like, what is the role? What's the description, the job description? What's expected? What are the benchmarks? Appropriate feedback, ensuring that the administrative role really aligns with incentives, and again, really encouraging that transparency.
And then looking ahead, and I would like to call on all of you just to kind of give me your thoughts on this as we're kind of starting to wrap up, and we'll obviously keep an eye on if there are any questions that are coming in live. As you continue to look ahead in the environments that we are facing, how do you see the role of surgeons evolving beyond the OR in the next decade as healthcare continues to morph and change into everything from like value-based medicine to everything else that we're dealing with on the healthcare front?
I would say that I think surgeons and surgeon leaders are really going to evolve in addressing systemic inequities and shaping health policy and driving data-informed transformation across care delivery systems. I think that we're going to be addressing social determinants of health. We're going to be leading in innovations in digital health. We're going to be advocating for inclusive policies and really holding systems accountable.
I think you touched on the digital health thing. I think that's a whole webinar in itself, but I think that is on the horizon. Dr. Gantt, Dr. Rabaglia.
I think surgeons have such a big perspective, and more are moving into major roles, such as presidents of whole health systems, deans, roles like that. I mean, the president and dean at my medical school are both surgeons. So we really do have that big picture, and as long as if you can throw in leadership and some emotional intelligence, we really are the complete package.
I agree, and I agree with everything that's been said so far. And I also think that, you know, the changing landscape of healthcare, the economics of healthcare make it more and more important that surgeons, physicians of any kind, but surgeons in particular, understand the operational and financial challenges of healthcare. Because I think only by understanding the drivers can you really innovate in the space. And I think we're going to have to really have a great understanding of that to help shape what the future looks like.
It's probably a four-legged, not a three-legged stool.
Yeah. We've done a really disservice to our residents by not training them as well as they should be trained in the business of medicine.
Yes.
I mean, we've done a disservice to our medical students. Before the 80-hour work hour restrictions, we had a month-long rotation where our residents spent it with the hospital lawyers. And they went to depositions, they went to court, they spent time in the risk office. They came back, changed physicians as far as their documentation and everything else. So, you know, a rotation for our residents with the hospital lawyers and the hospital administrators,
Yeah.
you know, with the chief financial officer, would be just eye-opening for them, but also make them realize that some of them will have a gift for being able to do that. A surgeon we all know, Margaret Dunn, when she got to Dayton to Wright State and was had a position there primarily because her husband fell in love with a spot there. So she ended up there, and the chair asked her to go to the overall business meeting, and she realized that she could read a spreadsheet and she understood it really, really well. So when we find out that we have those abilities, it really is eye-opening and door-opening for us.
Yeah. I mean, I didn't plant that, but at our National Society, I actually spearheaded the business and medicine course. And we've been doing it now for a few years, everything from contract negotiations to understanding the billing and coding to understanding Medicare reforms. And as women also, speaking of like even the insurance side of things, like how do you want to insure yourself? All of those things that we just don't get told or taught, because focus on the patient care and focus on that. But if you don't get that rounded out, it's very difficult. I do want to touch on one of the questions that came through. So I'll just read it verbatim, and then I'd like all of you to just kind of think about it. Obviously, a transition from clinical to administrative work is one career trajectory. On the other hand, how would you decide when to turn leadership over to someone else, perhaps a mentee or a younger partner? And also, could you describe some of your long-term goals as an example? So I think the first question that I would be curious about is, when do you decide it's time to start thinking about your succession plan? Like, when is that kind of inflection point for you?
When it's
Yeah.
not fun, when it's not fun anymore,
Yeah.
or when you identify someone who could be mentored into your role. I'm interested to hear Dr. Rabaglia.
Yeah, no, I think it's interesting because you're always looking to develop your bench strength, right? And I had a really great conversation with a wise mentor recently, and their perspective was, if I am 70 or 80% comfortable with the work that I am doing, then I've probably been doing it too long. And I need to move on and find something that is more challenging and that makes me more uncomfortable. And I think that's a really interesting perspective because, that does kind of encapsulate, how you push yourself to that next level, that next challenge. And then having that eye toward developing the bench strength so that you're developing that bench all along. And you have the next person up. I think putting those two things together is key.
I think that's an interesting thing because it talks about what you also need to bring, that passion. If you are in cruise control, maybe the passion's not there. I think that's a very interesting perspective. And then I think the latter part of that was also just describe what your long-term goals might be as an example. That's the next part of that trajectory. Are you looking for the next passion project or?
It's similar to what I've said before. I think it's all about the mindset and being open to the opportunities that are out there, right? And sometimes when you're kind of heads down, you don't even appreciate or see some of the things that are coming along. I think that you have to have an idea of where you want to go next. But sometimes you won't know what that is until that opportunity arises. And so you really just think it's about being open to what are the possibilities from here. What I know what my skill sets are, I know what my wheelhouse is, I know what I'm passionate about, but there might be 4 or 5 different roads that you can take. And, you never know which road is going to open and when. And, life is also about timing. And so that the door and your life timing have to align for you to walk through it.
I'm going to reflect on something that I remember I was giving a talk to younger MBA students that were doing the MD MBA. And someone asked me about the pathway of leadership. And I realized, and I kind of said it on the fly, I had no intention of doing any of this stuff when I started, none of it. And I realized that my trajectory was not by design, but it was by default. And then when I looked at it a little bit more closely, like, what was I saying? Because I said it out loud. I said, no, this was not by design. This was by default. What I was getting at was I didn't have a design to say I was going to get from here to here. But what I started doing, to the language that we've all used, is I started finding passion projects that really drove me. I really was about trying to make systems changes, operational efficiency changes, cost containment changes, ... And I kept working on those things. And then by default, I kept getting roped into other things. So I think that is really important because then and even now, I'm not really sure where I'm headed, but I know that I'll get there. But I'm not going to be bored, to your point. It's not going to be something like that. So I want to just keep it open. But there's another question, and I think we're going to start slowly wrapping it up. From your experience, what is the most important factor in being selected for parallel leadership roles in addition to clinical work? It sometimes seems that certain individuals are consistently tapped for these opportunities. What, in your opinion, makes someone more visible and credible to those making those decisions? And how do you navigate team dynamics or perceptions when stepping into these roles, meaning shifting away from your clinical work, which you touched on earlier? But I think it is kind of interesting, like it does seem like sometimes the same people keep getting tapped for the same stuff. And what does make someone become more visible and credible in the eyes of those people doing the tapping, so to speak?
Yeah, well, you have to figure out who's doing the tapping and what their motivation is for, do they want someone who looks just like them? Or what are their criteria for selecting that individual? It should be transparent, right? And it should be intentional. And it sounds like if someone's in an environment where they are demonstrating that they have a skill set or they're demonstrating interest and they're not getting chosen, then they need to find a sponsor. They need to find someone who will help them open the door or make it apparent to whoever's doing the tapping that they would be a candidate for that position also. It's tough. It all depends on the culture of the institution,
It
doesn't
does.
it?
The
Yeah.
culture really, what
Yeah.
is that old saying? Culture eats
Yep.
structure for breakfast.
Yep.
Yeah. This one's going to be a little tougher, but I think it is important and probably on everybody's mind, like mine, right? How have you successfully negotiated for protected time recognition or career advancement when your administrative contributions tend to fall outside of the traditional RVU-based models for promotion pathways, especially in institutions that may or may not have had, that mature structure to support surgical leaders? And Dr. Berry, I'm going to kind of turn to you on some of this too, if you don't mind.
Sure, yes. So I have been able to successfully negotiate protected time for administrative roles. I think I think the strategy behind that, number one is precedent. So that individual who was in the role before you, um, you know, um, likely had protected time. I think it's also looking at the job description and saying, okay, here's what is expected of me. And in order to set me up for success and to be successful in the role, I'm going to need this amount of time to be able to do that. And I think you have to feel empowered to advocate for yourself, and ensure that you're not going to be in a role where it's a 60% administrative role, but you're 100% clinical. You have to sort of have those conversations and discussions before accepting the role and ensure that it's written down in a contract before you say yes.
Any other thoughts before I ask a follow-up on that?
I think it's always about the value proposition, right? And sometimes that's hard to frame, but there are creative ways of framing up that value. And it might be a very specific ROI. It might be, harder to make that connection. But I think that finding, if you can align it to alleviation of pain points of your leaders, the department, whatever that is, you get that much closer, right? So take your passion, take your thoughts, try and find a way to align it to the organizational needs or the departmental needs and pain points, and you have a value proposition.
We touched on this earlier. I think Dr. Gantt, you made a comment about, and I wrote it down, the housekeeping administrative roles, the stuff that doesn't pay, so to speak. To kind of wrap this thought up, though, is it ever worth it to say, let's say I have a chairman or a division chief that's like, I got no money for this. I don't really have, but we need this done. Is it ever worth it to just say, okay, I'm going to do this? Or are you setting yourself up for, okay. Because,
No.
you worry, am I setting myself up for never allowing myself the protected time to do? So let me know your thoughts on that. Because
sometimes there are things that don't exactly fit in your long-term goals, or your way of getting, or even congruous with your mission. But if you can negotiate and say, okay, I love the pain points analogy, because that is absolutely okay. I will take care of this for you for 2 years. But then when this is over, during that time, I want you to develop the position of Chief Surgical Quality Officer, and that is my job. I get that position because you will have funding for it in 2 years. In the meantime, I will handle this for you. It is off your plate. Who can't say yes to that?
I think that's really important because a lot of us worry that we're going to keep doing this over and over and over again. And Dr. Berry's point earlier was, you really need to get that protected time, because I think you also have to set that standard. But I love what you just said, which is that you also set a time frame and say, I will give you this in return. It's a negotiation in return for this. And maybe have it in writing, maybe have it in an email, something perhaps to kind of protect ourselves a little bit more. So I want to just start kind of closing things out. We have about 5 minutes, so I'll leave it open for the chat to see if we have any more. But I really, really want to thank all of you for joining us today. If you have any last minute thoughts, please interrupt me. I want to thank our panelists for sharing all of your expertise and your experiences. The recording of today's webinar will be available on the ACS YouTube channel. Oh, we still have a question, so I'm going to stop there for a second. I love it. How do you diplomatically address resistance from clinical colleagues or department leaders who may see your administrative work as a distraction or a threat to shared work balance? Oh dear. Left the best one for last. How do we manage the people around us who see this as a threat?
Outline all the things that need to be done and see what they want to do, right? I mean, if you're doing something that your department needs or division or whatever to be successful, and you're willing to do that, then it's going to take a little bit of clinical time, but you're the one doing it, they're not.
Yeah.
I think that's key. And, again, it's about that value proposition. And maybe for them, it's about, do you see the seat at the table? And, tell me your pain points. Let's talk about that. Maybe I can bring some of that forward. We have a seat in the conversation as a team, as a group. And that can be really powerful. So I agree with what Dr. Gantt said. And it's difficult to strike that balance, because every minute that you spend elsewhere puts an extra minute on the team, right? But I think it's figuring out a way to show that value and that you are creating opportunity for the team.
And sometimes also just creating some elbow room for other people, because I think people feel very threatened. There's only one seat at that table and you have it. I really do want to thank all of you, Dr. Rabaglia, Gantt, and Dr. Berry, for your time today. I think you've all shared some really nice insights. I've taken a few notes and some quotes that I hope to use and obviously credit you. Again, just a recording of today's session will be available on the ACS YouTube channel. And please join us and the ACS Women in Surgery Committee on Thursday, August 21st for their next webinar, Seizing the Moment, Following an Unexpected Path to a Fulfilling Surgical Career. And more information is available for everybody on the facs.org on the Women in Surgery Committee webpage. I really want to thank all of you. It was really fun listening to each of you, and just kind of there's a lot of commonality, but clearly different trajectories in each of your career pathways. And the responsibilities you take care of, and the fact that you were able to spend an hour of your busy lives telling us about it. I do thank you for that, and we wish everybody a good evening. Thank you so much.